At the outset, let me emphasize what is a normal optic disc. A normal optic disc has well-defined margins. It has a thin neuroretinal rim, and importantly, the nerve fiber layer is transparent. The nerve fiber layer is transparent, and in majority of individuals, majority of normal individuals, one can see like this. A true optic disc edema is a result of axonal swelling. It is basically axoplasmic stasis which leads to this edema. If the underlying process is raised intracranial pressure, it is called lateral edema. Whereas, but if I show you something like this, then we have to put a reasoning process. The reasoning process to differentiate true edema from pseudo edema. And it also includes science and investigation, but in this talk I am confining to the science of this reasoning. This examination is taught in relation with glaucomatous optic disc, and we think that the template is applicable only to glaucoma, but that's not true. It's a template which is applicable to any optic neuropathy, and I'll show you how this helps us even to distinguish the true edema from a pseudo edema. So the first step of the template is look at size, shape and margin of the disc. You don't pay much attention to this, but in optic disc edema you have a blurred or ill-defined margin of the optic disc. The next thing is to look at the neuroretinal disc. Look at this disc. This is a failed, this edematic disc, the neuroretinal disc is failed, so this is classically called a pallid optic disc edema. Then we come to the surface of the optic disc. We look at the optic disc hemorrhages. Alongside hemorrhages, those are on the surface. We should also look for hard exudates and pulsations of the vessels. Both these images have nerve fiber layer hemorrhages. But this hemorrhage is in the presence of an optic disc notch and a nerve fiber layer. This becomes glaucoma, and this is accompanying a swollen optic disc, which has a different name. And this disc has hard exudates. The next thing is to look at the nerve fiber layer. The nerve fiber layer doesn't mean one should look only for the defects in the RNFX. It can also mean edema or swelling. This is very early disc edema. This is axoplasmic stasis at the core. This is very early disc edema. It can also mean pattern line, which you will see in resolved pattern. So this is the template. And if you use this template, we can differentiate true edema from pseudo edema. Let us look at these photographs. These photographs are from a 46-year-old lady who complained of chronic headaches for past several months. Her vision was 20/20, color vision was normal, but the discs are swollen. We cannot see the disc margin. The disc margin is blurred. If you look at the vessels, because there is swelling of the nerve fiber here, we cannot trace the vessels. The vessels are obscured. We cannot trace them through the disc margin. Okay, there are hemorrhages. Okay, there are no hard exudates, but there are hemorrhages. Look at the veins. The veins are dilated. So these are all signs of true disc edema. And the neuroretinal rim is fortunately pink. That indicates that this is a relatively recent onset. In contrast to this patient has a long-standing pattern edema, and we see that the neuroretinal rim here is pale. In addition to all other signs, this pallor of the neuroretinal rim indicates that this is a long-standing true edema of the disc. And if you take a closer look at this disc, you will see these deposits. These are long-standing deposits. These are also called pseudo-lucent optic disc. This is another example of bilateral disc edema. This is true disc edema, and Dr. Satyakarna will tell you whether this is bilateral papilledema or bilateral disc edema, which is not papilledema. Let us look at this disc. This early edema is one which can be easily missed. Okay, this early edema, compare this disc with this. This is angry looking. The veins are dilated, and look at the nerve fiber layer. The nerve fiber layer is edematic. This is opaque nerve fiber layer. This is not transparent. This nerve fiber layer is transparent, whereas this is opaque. and this is obscuring the small vessel. Because this is in early stage, the small vessels are obscured, larger ones we can trace. These signs indicate that this is true optic disc edema. This is another classic picture of neuroretinite. So you two similar looking, both the discs are swollen. Look at the nerve fiber there, it is elevated. Okay, one may think that this is true edema. Show you another comparative image. Look at this. Even this is a swollen disc. What's the difference? The difference is in the nerve fiber layer. This nerve fiber layer is opaque, and this nerve fiber layer is transparent. Okay, what we see here, temporal pallor is a photographic artifact. This disc was a normal disc. This is a small disc which is inserted at an oblique angle. That's why the nerve fiber layer has to climb to the disc. But it is transparent nerve fiber layer. We can beautifully trace all the vessels. The veins are of normal caliber. There are no exudates, there are no hemorrhages. So this is pseudo-papilledema. And this is a true papilledema. This is a true disc edema. This was papilledema. Now look at this. This is also a grossly swollen disc. Now we put the template. Disc margin is well defined. Neuroretinal ring is clean. But we can trace all the vessels. Nerve fiber layer is elevated, but it is transparent. We can trace all the vessels. Veins are of normal caliber. There are no exudates. There are no hemorrhages. So this is pseudo-papilledema. This patient had optic disc bruisers, which was confirmed obviously. So if we don't put the template and just look at the swollen optic disc, we may carry it away and say that this is true disc edema. These are another typical examples of pseudo-disc edema, which are often classified as true disc edema. This is disc at risk. It's a small crowded disc which is more prone for developing ischemic optic neuropathy. Because it's a small disc, the nerve fiber layer has to climb up to the disc. It is crowded and it may give an impression that it is disc edema, but that is not. Similar features are seen in hyperopic disc. This patient has myelinated nerve fibers and again can be mistaken for a true disc edema, that is not. In addition to that, interestingly, this was a young patient and also had temporal pallor of the optic disc. Actually, this patient had primary optic atrophy. This is another example of a disc edema. But you see something here in the macula. This is hypertonic maculopathy. This patient had glaucoma surgery in the past, and there was whole filtering blood that has resulted in hypertonia. This is disc edema. Axoplasmic stasis because of ocular hypertonia. The clue is the maculopathy. But again, this is edema because of hypertonia, not because of raised intracranial pressure. This table tells us the distinction what I showed you earlier. The important features of this distinction are opacity of the nerve fiber layer, obscuration of the vessels, presence of hemorrhages, hard exudates, and absence of spontaneous venous pulsation in case of true disc edema. If the intracranial pressure is raised, the venous pulsations they will disappear if there is raised intracranial pressure. If you have seen the patient in the earlier stage when the pulsations were present on the disc and later on they disappeared, it is strongly indicative of raised intracranial pressure. So all these features will help you in arriving at a correct diagnosis when you arrive at the stage of disc.